Chapter 11, Complex Surgical Instruments. Welcome to our comprehensive study of Chapter 11, focusing on complex surgical instruments. This chapter marks a significant transition in your training as a sterile processing technician. We are moving beyond basic stainless steel instrumentation into the era of advanced medical technology. As surgical procedures have evolved to become less invasive and more effective for patients, the instruments used to perform them have become increasingly sophisticated. We begin by defining exactly what makes an instrument complex. In the context of sterile processing, complex surgical instruments are defined by their intricate designs. Unlike a simple hemostat or retractor, these devices often feature multiple moving parts, narrow lumens, delicate optical components, and internal channels that are difficult to access. These design features make them exceptionally challenging to clean and inspect. The stakes in processing these items are incredibly high. If a technician fails to properly clean and sterilize a complex device, it can lead to the formation of biofilm, permanent damage to the expensive device, and most critically, the transmission of healthcare-associated infections, HAIs, to the patient. Before we delve into specific devices, we must establish the golden rule of this chapter. Throughout your study of complex instruments, one theme will recur constantly. That theme is the absolute necessity of obtaining and strictly following the device manufacturer's written instructions for use, or IFU. As we have discussed previously, the device manufacturer is the only entity that has validated the cleaning and sterilization process for their specific device. Sterile processing technicians must never rely on memory, guesswork, or general rules of thumb when processing these items. You must consult the current IFU for every specific model to ensure patient safety and regulatory compliance. For those preparing for the certification exam, it is crucial to remember that the 9th edition emphasizes the manufacturer's IFU as the ultimate authority. However, in the current professional reality, while the IFU remains the legal standard, recent industry updates, such as AAMI ST91, have introduced stricter guidelines, particularly for endoscopes. These new standards may require steps that exceed the manufacturer's minimums, such as the use of lighted magnification during inspection or the use of active drying cabinets. While you must always comply with the IFU, you should also be aware of these elevated industry standards that prioritize patient safety. We will now begin our technical review with the first major category of complex devices, which are powered surgical instruments. Powered surgical instruments are complex devices utilized for heavy-duty tasks such as cutting, drilling, reaming, and screwing bone, as well as for delicate tasks like shaving and removing tissue. Common examples you will encounter include sternum saws used in cardiac surgery, orthopedic drills used for joint replacements, and dermatomes used for harvesting skin grafts. Structurally, these instruments generally consist of a handpiece, which houses the motor, and various attachments such as collets, chucks, blades, and burrs. The most fundamental step in processing these devices is identifying their power source. The sterile processing technician must identify how the instrument is powered, as this dictates specific handling, cleaning, and inspection requirements. There are 3 main power sources you must be able to identify. The first power source is electric. These instruments are powered by a direct cable connection to a console or a wall unit. When processing electric instruments, the primary area of concern regarding the power source is the electrical cable itself. This cable is a critical component. Technicians must meticulously inspect the cord for cuts, nicks, or exposed wiring in the insulation. Any breach in the cord's integrity could cause electrical shock to the surgical team or create short circuits that disable the device during a procedure. The second power source is pneumatic, or air-powered. These devices are powered by compressed gas, typically nitrogen, which is delivered through a hose. This hose connects the instrument to a regulator panel on the wall or a tank in the operating room. Similar to electric cables, these hoses require careful inspection. You must check for air leaks, bubbles, or cracks in the outer casing. The proper method for inspecting a pneumatic hose is to pressurize it. You must fill the hose with compressed air to check its integrity. This ensures that the hose will not leak gas during surgery and, conversely, will not allow fluids to seep inside the hose during cleaning. The third power source is battery. These instruments rely on a rechargeable battery pack that attaches to the handpiece. These batteries typically utilize nickel-cadmium or lithium-ion technology. A critical processing rule for battery-powered devices is that the batteries and the handpieces are usually processed separately to ensure proper sterilization and to protect the battery cells from damage. Having identified the power sources, we now move to the most critical phase of processing powered surgical instruments, which is decontamination and cleaning. The decontamination of these devices requires extreme caution because the internal mechanism, containing the motor, gears, and electrical components, is highly susceptible to damage from moisture and heat. The first concept you must master is known as the immersion rule. For the purposes of your exam and general safety, manual cleaning is the standard. Unlike stainless steel hand instruments, powered instruments generally should not be processed in mechanical washers or ultrasonic cleaners unless explicitly authorized by the manufacturer's IFU. Most powered handpieces must never be immersed in water or cleaning solution. Water penetration into the internal mechanism, known as fluid invasion, is the number one cause of damage to these expensive devices. If fluid invades the casing, it can corrode the motor, cause permanent electrical shorts, and ruin the delicate gears. To prevent this catastrophic fluid invasion during the cleaning process, technicians must often utilize a specialized accessory known as a decontamination battery or a decontamination hose. Sometimes referred to in the field as a dummy battery, the primary purpose of this accessory is not to power the device, but to create a watertight seal. This seal protects the electrical contacts and internal components from water and detergent entry. If the specific device requires a decontamination hose or battery, it must be connected securely before any cleaning begins. Failure to attach this protective seal before bringing the device near water is a critical error. The cleaning process itself typically involves wiping the external surfaces with a soft sponge or cloth dampened with a neutral pH enzymatic detergent solution. You must avoid using abrasive pads that could scratch the surface. Special attention must be paid to the distal tip and the collet. The collet is the mechanical collar where the saw blade or drill bit attaches. Technicians should use soft bristled brushes to meticulously clean the collet and any moving parts. Even a small amount of bone debris or dried blood left in the collet can cause the mechanism to jam during surgery, rendering the drill useless. Remember to never immerse the device during this process unless the IFU specifically permits it. Also, be wary of saline solutions. Saline can cause rapid pitting and corrosion of metal components and should be avoided during cleaning. Once the device is clean, we proceed to inspection and testing. Functional testing and inspection of powered instruments and their accessories are critical to ensure they work correctly when the surgeon needs them. For pneumatic instruments, we return to the hose inspection method we discussed. You must inspect the hose for integrity by pressurizing it with compressed air to ensure there are no leaks. For electric instruments, you must carefully inspect the electrical cable for cuts, cracks in the insulation, or exposed wiring that could pose a safety hazard. A functional check is also required. After cleaning and before sterilization, the device should be tested to verify it runs smoothly. This involves assembling the unit with an attachment and running it for a brief period. Listen for unusual noises, excessive vibration, or overheating. However, it is vital to remember that after this test is complete, the unit must be disassembled again for sterilization. You cannot sterilize a powered instrument with the attachments or batteries connected. Finally, we must address lubrication. Many powered instruments require lubrication, or oiling, to keep the internal gears moving smoothly. This step typically occurs after cleaning and before sterilization. You must perform this strictly according to the manufacturer's IFU, using only the specified sterilizable lubricant. Using the wrong oil can gum up the motor or interfere with sterilization. We conclude our discussion on powered surgical instruments by addressing their specific sterilization requirements. Because these devices are dense, heavy, and complex, they often require specific sterilization cycles to ensure steam penetration and drying. Most powered instruments are processed using pre-vacuum steam cycles, and manufacturers often mandate extended exposure times or extended drying times to account for the mass of the metal. The most critical rule for sterilization is disassembly. Any removable parts, such as saw blades, drill bits, or attachments, must be removed from the handpiece. They cannot be sterilized while connected. Furthermore, we must exercise extreme caution with batteries. Batteries must generally be removed and processed separately from the handpiece. This is a safety imperative because the high heat of steam sterilization can damage the battery cells or, in severe cases, cause them to explode if they are sealed incorrectly or processed in the wrong cycle. Never sterilize a battery unless the manufacturer states it is autoclave safe. While some modern batteries can withstand steam, many require low-temperature sterilization, such as hydrogen peroxide gas plasma, or specific low-temperature steam cycles to prevent catastrophic failure. We now transition to one of the most significant topics in this chapter, endoscopes. An endoscope is a specialized instrument used to examine the interior of a hollow organ or body cavity. The term itself is derived from the Greek words endo, meaning inside, and scopion, meaning to examine. These devices are among the most complex, expensive, and delicate tools handled by sterile processing technicians. Endoscopes are generally classified into three categories based on their physical flexibility and intended use. First, we have rigid endoscopes, which are metal tubes with lenses that do not bend. Second, we have semi-rigid endoscopes, which are very thin tubes that allow for very slight flexing without breaking. Third, we have flexible endoscopes, which are complex tubes with internal fiber optics and cables that allow the tip to bend and articulate freely. Within these categories, technicians must distinguish between non-operative and operative scopes. Non-operative scopes are used solely for viewing anatomy, diagnostic. Operative scopes, however, feature a working channel, or lumen, which runs the length of the device. This channel allows the surgeon to pass instruments to the site or to perform suction and irrigation. From a processing standpoint, operative scopes are significantly more difficult to clean because this internal channel becomes a reservoir for bioburden and must be thoroughly brushed and flushed. A critical safety concept applicable to all endoscopes involves the light source. The scope itself does not generate light. It connects to an external high-intensity light source via a fiber optic light cable. A major safety hazard to remember is that these light cables get extremely hot during use. Never place a hot light cable on surgical drapes or the patient's skin. The intense heat can cause surgical fires or severe burns to the patient. Let us focus now on rigid endoscopes. Often called telescopes in the operating room, these are the most common scopes you will process. They feature a solid metal shaft and typically utilize a technology called the rod lens system. Unlike a hollow tube, the shaft of a rigid scope is filled with a series of glass rods that transmit light and images with high clarity. Because the tube is filled with glass, these devices are extremely fragile. They do not bend. If a rigid scope is bent or dropped even a few inches, the internal glass rods will shatter, destroying the image. Rigid scopes are available in various viewing angles to allow the surgeon to see around corners. These angles include 0 degrees for forward viewing, 30 or 45 degrees for forward oblique viewing, and 70 or 90 degrees for side viewing. The angle is usually engraved on the eyepiece. While manufacturers often use color-coded bands around the eyepiece to indicate the angle, such as green for 0 degrees, these codes vary by brand. Therefore, technicians must always read the engraving to confirm the correct scope. When cleaning rigid scopes, you must treat them with the utmost care. They must be transported in a container that prevents them from rolling or impacting other instruments. Manual cleaning is the standard method, using neutral pH enzymatic detergents. You should avoid acidic or alkaline solutions as they can damage the adhesive that holds the lenses in place. If the scope is operative and has a working channel, that channel must be brushed. Finally, pay attention to the ultrasonic warning. Do not process rigid scopes in ultrasonic cleaners unless the manufacturer explicitly approves it. The high-frequency vibrations of the ultrasonic cleaner can easily shatter the delicate glass rod lenses inside the shaft. Following the cleaning process, every rigid endoscope must undergo a rigorous inspection protocol. Because these devices rely on internal optics, they must be inspected for both physical damage and image quality. This is not a cursory glance, it is a multi-step verification process. First, you must perform a light output test. Shine a light into the light post of the scope and check the distal tip. The light emerging from the tip should be bright and clear. If the light appears dim or has a yellow tint, it indicates that the internal fibers are damaged or aging, and the scope will not provide sufficient illumination for the surgeon. Second, you must perform an image quality test. Hold the distal tip of the scope approximately 2 to 3 inches above a sample of written text, such as a protocol card or a package label. Look through the eyepiece. The letters should appear crisp, distinct, and legible. If the image is foggy, distorted, or blurry at the edges, the internal lens system is damaged, and the scope must be removed from service. Third, perform a fiber optic light test. Hold the light post end up to a light source and look directly at the distal end. You are looking for black dots. If you see black dots in the field of view, it indicates broken glass fibers inside the scope. These broken fibers reduce light transmission, making the surgical site too dark for the surgeon to see. If significant dark spots are present, the scope is defective. Finally, inspect the distal tip itself. Check for any scratches or cracks on the objective lens. Even a microscopic crack can allow fluid to enter the scope during sterilization or surgery, causing the lens to fog up and blinding the surgeon during the procedure. We now move to a specialized subset known as semi-rigid endoscopes. These scopes generally have a very small diameter, often appearing needle-like. They are primarily used in urology, specifically as ureteroscopes to view the narrow ureters and kidneys. Although they are called semi-rigid, do not be misled by the name. They are extremely fragile. They can bend slightly to accommodate anatomy, but if bent too far, the internal fiber optics or the shaft will break. The handling rule for these devices is to treat them exactly like a rigid scope. You must never attempt to coil them like a flexible scope during storage or sterilization. Closely related to rigid scopes are the instruments used alongside them, known as rigid endoscopic or laparoscopic instruments. These include graspers, scissors, and dissectors that pass through ports into the body. The most critical safety issue with these devices is insulation failure. Laparoscopic instruments are covered with a plastic insulation coating to prevent electricity from escaping during electrosurgery. A microscopic pinhole or crack in this insulation can allow electricity to arc to nearby organs, such as the bowel, causing severe burns that may not be noticed immediately by the surgeon. To prevent this, SP technicians must use an electronic insulation tester, often called a lap tester, on the shaft of every insulated instrument every time it is processed. It is a critical exam point to remember that this electronic insulation testing should be performed in the clean assembly area prior to set assembly. It should not be performed in the decontamination area. The instrument must be clean and dry for the test to be valid and safe. If the tester detects a leak in the insulation, the instrument must be discarded or sent for repair immediately. Having examined rigid systems, we now turn our attention to the most intricate devices in the sterile processing department, which are flexible endoscopes. Flexible endoscopes are notoriously difficult to process due to their length, their extremely narrow lumens, and their heat sensitivity. Unlike rigid scopes which use glass rods, the insertion tube of these devices is flexible, utilizing internal fiber optics or electronic video chips to visualize the body's internal anatomy. This design allows the instrument to navigate through curved anatomical structures, such as the colon or the bronchi, which would be impossible with a rigid tube. To properly clean and handle these devices, the sterile processing technician must be able to identify their 6 standard components. While designs vary by manufacturer, the basic anatomy remains consistent. The first component is the light guide connector. This is the end of the scope that plugs directly into the light source tower. It is a solid, heavy connector that often houses the electrical contacts for video signals. Crucially for the technician, this connector also houses the vent used for leak testing. This is where you will attach your leak tester to check for holes. The second component is the universal cord, also known as the umbilical cord. This is the thick tube that connects the light guide connector to the main body of the scope. It transmits light, air, and water from the tower up to the physician's hands. The third component is the control body. This is the head of the scope that is held by the physician during the procedure. It is the command center of the device. The control body contains the angulation knobs, which are wheels used to steer the tip of the scope up, down, left, and right. It also houses the air/water and suction valves, which control fluid flow. Finally, the control body contains the instrument channel, sometimes called the biopsy port. This is the opening where the surgeon inserts flexible tools, such as biopsy forceps, to collect tissue samples. The fourth component is the insertion tube. This is the long, flexible tube that actually enters the patient's body. It houses the internal working channels, the fiber optic light bundles, and the image system. It is covered in a delicate sheath that protects these internal components from fluid. The fifth component is the bending section. Located at the very end of the insertion tube, just before the tip, this section is designed to articulate. It contains a series of internal metal links, similar to a spine, that allow the tip to bend when the angulation knobs are turned. Because this section is constantly flexing, the rubber sheath covering it is prone to stretching and tearing. The sixth and final component is the distal tip. This is the very end of the scope. It contains the camera lens or video chip, the lenses for the light guide, and the tiny opening of the working channel. This tip is the most delicate part of the entire instrument. Impacting the distal tip against a wall or sink can shatter the lens and ruin the scope. It is also important to note that some specialized scopes, particularly duodenoscopes, feature a movable elevator mechanism at the distal tip. This complex hinged area allows the physician to guide instruments but is a notorious hiding place for bacteria and requires meticulous attention during cleaning. Understanding this anatomy is the prerequisite for the cleaning process. Because these scopes contain multiple channels running from the control body to the distal tip, and separate channels for air and water, the cleaning protocol is a strictly regulated multi-step procedure. Understanding the anatomy of a flexible endoscope leads us directly to the first and arguably most critical phase of reprocessing, which is point-of-use treatment. This process, formerly known as pre-cleaning, must begin immediately at the patient's bedside, right after the procedure is finished. The clock starts ticking the moment the scope is removed from the patient. The primary goal of point-of-use treatment is to prevent organic soil, such as blood, feces, or mucus, from drying on the surfaces or inside the channels. Biofilm can form within minutes of use, and once established, it is highly resistant to disinfectants and difficult to remove. Therefore, the exterior of the scope must be wiped down with a lint-free cloth or sponge soaked in enzymatic detergent. Crucially, detergent solution must be suctioned through the working channel. This step flushes out gross debris while it is still wet. If this step is skipped, the narrow lumen may become permanently clogged, rendering the scope useless. Once the point-of-use treatment is complete, the soiled scope must be transported to the decontamination area. To prevent the remaining soil from drying during transport, the scope must be kept moist. This is typically achieved by placing the scope in a container with a damp towel or treating it with a commercial enzymatic spray designed to retain moisture. The scope should be coiled loosely in a leak-proof container. tightly coiling the scope can damage the delicate fiber optics inside the insertion tube. Upon arrival in the decontamination area, the first step is not cleaning, but leak testing. This is the most critical safety step for the device itself. A leak test identifies microscopic holes in the exterior sheath or the internal channels. It must be performed after point-of-use treatment but before manual cleaning or any immersion in fluid. The danger here is fluid invasion. If a scope with a puncture is submerged in a sink of water or cleaning solution, fluid will rush inside the protective sheath. This fluid will invade the internal mechanics, corrode the angulation wires, and destroy the fiber optics or video chip. A single instance of fluid invasion can cause catastrophic damage, costing thousands of dollars to repair and creating a permanent breeding ground for bacteria inside the device. There are two primary methods for leak testing. The first is a dry test. In this method, you attach a tester to the scope's vent, pressurize the scope with air, and monitor a gauge for pressure loss. If the needle on the gauge drops, air is escaping, meaning there is a leak. The second and more common method is a wet test. This involves pressurizing the scope with air first, and then submerging the pressurized scope in clear water. The technician then looks for a continuous stream of bubbles rising from the scope, similar to finding a leak in a bicycle tire. A steady stream of bubbles indicates a hole. During the wet test, you must follow a specific manipulation rule. You must flex the bending section of the scope in all directions and manipulate the control knobs. Some small holes are sealed shut when the rubber is relaxed and only open up when the rubber is stretched or bent. If you do not move the distal tip during the test, you may miss a leak. If a leak is detected, the test stops immediately. The scope is removed from the water, marked as damaged, and sent for repair. It must never be used on a patient. Once the leak test confirms the scope is intact, we proceed immediately to the most labor-intensive and vital part of the process, which is manual cleaning. It is a fundamental truth in sterile processing that you cannot disinfect or sterilize a dirty surface. If biofilm or debris remains inside a channel, the high-level disinfectant, HLD, used in later steps will not be able to penetrate it, and the device will remain contaminated. The manual cleaning process begins with immersion. The sink must be filled with fresh water and a measured amount of enzymatic detergent. The scope is fully immersed in this solution. At this stage, disassembly is required. You must remove all detachable parts, such as the air/water valves, suction valves, and biopsy caps. These small parts are often cleaned separately, sometimes requiring ultrasonic cleaning in a small basket, to ensure their intricate springs and seals are free of debris. We must also address the cleaning of endoscope accessories. Reusable items such as biopsy forceps or snares often require ultrasonic cleaning to dislodge soil from their coiled metal sheaths before they can be sterilized. Next, we move to brushing. This is the primary method for removing soil from the long, narrow internal channels. You must select a brush of the exact diameter and length specified by the manufacturer's IFU. This precision is critical. If the brush is too small, the bristles will not touch the channel walls, and no scrubbing action will occur. If the brush is too large, it can damage the delicate internal lining of the channel. The brushing technique follows a strict protocol. First, to protect yourself from aerosols, all brushing should be done under the surface of the water. Insert the brush into the channel opening and push it all the way through until the bristles emerge from the distal tip. Once the brush exits, use your fingers to wipe the bristles clean of any visible debris before pulling it back. Never pull a dirty brush back through the channel, as this simply redistributes the soil. This process of brushing and wiping must be repeated until the brush emerges completely clean, with no visible soil on the bristles. After the channels have been scrubbed, we proceed to flushing. Brushing loosens the soil, but flushing removes it. Using a syringe or a flushing pump, you must inject detergent solution through every channel to wash away the debris loosened by the brush. Following the detergent flush, the channels must be thoroughly rinsed. As we have noted previously, the quality of the rinse water matters. You must use the water quality recommended in the IFU, often treated or deionized water, to prevent mineral deposits from forming inside the channels. These deposits can damage the scope and interfere with sterilization. The final step before high-level disinfection is inspection and cleaning verification. Visual inspection should be performed using a lighted magnifier. You must closely examine the distal tip and the bending section for any residual debris, cracks, or damage that may have occurred during cleaning. However, visual inspection is often not enough for internal channels. Modern standards increasingly require the use of cleaning verification tools. Technologies such as ATP testing or protein swab tests are used to detect invisible organic residue. If a scope fails this verification test, it is considered dirty and must be sent back to the start of the cleaning process. Only when a scope is verified as clean can it move to the next stage of disinfection. Following successful cleaning and verification, the flexible endoscope must undergo microbial destruction. Because these devices are constructed with delicate polymers, rubbers, and adhesives, the vast majority are heat sensitive. Therefore, steam sterilization is generally strictly prohibited. Putting a flexible scope in a steam autoclave will melt the sheath and destroy the internal optics. Instead, we rely on two primary methods: high-level disinfection or low-temperature sterilization. The most common method for processing semi-critical scopes, such as those used in gastroenterology, is high-level disinfection, HLD. While this can be done manually, modern facilities primarily utilize automated endoscope reprocessors, known as AERs. These machines are designed to replace the manual soaking process. They offer significant safety advantages by strictly controlling the temperature of the disinfectant, ensuring the correct exposure time, and managing the critical rinsing phase. If manual disinfection is performed, or if the AER cycle fails, the technician must be acutely aware of the rinsing requirement. High-level disinfectants like glutaraldehyde or orthothialdehyde, OPA, are toxic. After the soak time is complete, the scope must be thoroughly rinsed with treated water. Failure to rinse the channels completely can leave chemical residue behind. If this residue enters the patient's body, it can cause severe chemical burns to the lining of the colon or esophagus, mimicking the symptoms of an infection and causing serious harm. For scopes that enter sterile tissue, or for facilities that prefer a higher margin of safety, low-temperature sterilization is used. Common methods include vaporized hydrogen peroxide or ethylene oxide, also known as ETO. There is a critical mechanical rule for ETO sterilization involving the venting cap. Because ETO sterilization utilizes a vacuum, the pressure inside the sterilizer chamber drops significantly. However, the air inside the airtight endoscope remains at normal pressure. This pressure difference causes the air inside the scope to expand, like a balloon. If the pressure cannot escape, the outer sheath of the scope will burst. Therefore, technicians must attach a specialized venting cap to the leak test port before placing the scope in the sterilizer. This cap allows air to vent out, equalizing the pressure. Conversely, you must remember to remove this cap before immersing the scope in fluid, or water will invade the device. Once the scope is processed, we move to storage, which is the final defense against infection. The golden rule of storage is that the scope must be completely dry. Moisture is the enemy. Even a single drop of water left in a channel can allow bacteria like Pseudomonas aeruginosa to multiply to dangerous levels during storage. To facilitate drying, flexible endoscopes should typically be hung vertically in a specialized storage cabinet. Gravity helps any remaining fluid drain out of the distal tip. Furthermore, all control valves, air/water buttons, and biopsy caps must be removed during storage. Do not leave them attached to the scope. Removing them prevents moisture from being trapped in the ports and allows air to circulate freely through the channels. Finally, we must address the transport of processed scopes. You should never store a clean scope in the padded carrying case used for shipping or transport. These foam-lined cases are impossible to clean effectively. They trap moisture and warmth, creating an incubator for bacteria. If a clean scope is placed in one of these cases for storage, it is considered contaminated and must be reprocessed. While the endoscope provides the view, the image is often captured and processed by a separate, high-tech component known as the endoscope camera. These camera heads attach to the eyepiece of rigid scopes or are integrated into the design of flexible ones. They contain highly sensitive electronic sensors and precision glass lenses. The most common error in processing cameras involves fluid damage. Unlike stainless steel instruments, camera heads and their long cables are not always submersible. You must check the manufacturer's IFU for every specific model. Some cameras are fully waterproof and can be soaked, while others must be only surface disinfected. If a camera is submersible, it often requires a watertight cap to be placed over the electrical connector before it touches water. This cap protects the delicate gold-plated pins from corrosion. If you forget this cap, the camera is ruined the moment it enters the sink. Inspection of the camera focuses on the cable. You must run your fingers along the length of the cord, feeling for herniations. A herniation is a bulge or separation in the outer rubber casing, indicating that the internal shielding has broken. This damage allows interference to disrupt the video signal, causing flickering or static on the surgeon's monitor. Additionally, the glass window of the camera head must be inspected for water spots or dried debris, which would obscure the view. From cameras, we step up to the pinnacle of complex instrumentation, which is robotic instruments. Robotic surgery is an evolution of minimally invasive surgery, most commonly utilizing systems like the Da Vinci robot. While the procedure is similar to laparoscopy, inserting instruments through ports, the instruments themselves are significantly more complex. The hallmark of these devices is the endo-wrist technology. This mechanism mimics the movements of the human hand, containing fine cables, pulleys, and gears that allow for 7 degrees of freedom. This allows the surgeon to perform delicate maneuvers deep inside the body. However, this complexity creates a nightmare for decontamination. The housing unit, which is the box-like end that attaches to the robot arm, and the distal tip are the primary areas where soil accumulates. To clean them, technicians must utilize specific flush ports found on the housing. You cannot simply soak these devices. You must use manufacturer-supplied flushing adapters to force cleaning solution into the internal housing and all the way down the shaft. Furthermore, unlike many powered instruments, most modern robotic instruments require ultrasonic cleaning as a mandatory step. They must be placed in specific racks or carriers that hold the instrument in a precise orientation. These racks often have manifold connections that pump fluid through the instrument while the ultrasonic energy releases the soil from the internal cables. Inspection of robotic instruments includes the standard insulation testing we discussed for laparoscopic tools. Because the shaft is insulated, it must be tested for pinholes to prevent electrical arcing. Additionally, you must inspect the wrist mechanism for broken or frayed cables. If a cable snaps during surgery, the instrument will freeze, potentially injuring the patient. A unique feature of robotic instruments that you must memorize for the exam is the concept of limited reuse. Most robotic arms are validated for a specific number of uses, typically 10 or 20 lives. The robotic console tracks this electronically, but SP technicians may also be required to manually track uses on the housing or via a log. Once the limit is reached, the instrument must be discarded, even if it appears to be in perfect condition. This is because the internal tension cables stretch over time and can fail unexpectedly after their rated life. Finally, regarding sterilization, robotic instruments are difficult to process due to their density. Pre-vacuum steam cycles are standard, but gravity displacement is generally not effective. Extended drying times are often mandated to ensure no moisture remains trapped inside the complex housing unit. For our final segment, we shift our focus from the delicate world of optics and robotics to the heavy-duty world of complex orthopedic instruments. Orthopedic surgery involves the treatment of the musculoskeletal system, including bones, joints, ligaments, and tendons. Instruments used for procedures such as total hip arthroplasty are designed to manipulate and cut through dense bone. Consequently, these sets are often the heaviest and most physically demanding trays in the sterile processing department. To identify these instruments properly, you must look at the working tips. First, we have rongeurs. These are heavy-duty cutting instruments used to bite off small pieces of bone or soft tissue. Because they must cut through bone, their sharpness is critical. A dull rongeur can crush bone rather than cut it, causing complications. Therefore, rongeurs must be tested for sharpness using a standard index card. The instrument should bite a clean hole through the card without tearing the paper. Next, you must distinguish between osteotomes and chisels. Both are used with a mallet to shape bone, but their tips differ. An osteotome has a double-beveled cutting edge, meaning it is tapered on both sides like a wedge, and is used to cut or split bone. A chisel has a single-beveled cutting edge, flat on one side and tapered on the other, used to shave or sculpt bone. Finally, we have reamers and rasps. These often feature rough surfaces that resemble a cheese grater. These surfaces are designed to hollow out bone channels for implants. Because of their texture, they shred tissue and are extremely difficult to clean. They must be meticulously brushed to remove every trace of bioburden from the teeth. Processing orthopedic sets presents a significant ergonomic challenge. Heavy items should always be stored on the middle shelves of storage racks. This keeps the trays in the power zone, between the waist and chest, allowing technicians to lift them safely using their legs and core rather than their back. There is also a critical safety limit you must memorize. When assembling these sets, the total weight of the container and instruments must not exceed 25 pounds. This limit is mandated by AAMI and OSHA guidelines not only to prevent staff injury but also to ensure that the sterilization steam can penetrate the set and dry it effectively. Closely related to orthopedics are implantable devices. Implants are foreign objects, such as screws, plates, or joint prosthetics, that are surgically placed inside the patient's body. Because these items remain in the body, they represent the highest infection risk. Therefore, biological monitoring is strictly required. A biological indicator, BI, process challenge device, PCD, must be run in every sterilizer load that contains an implant. Furthermore, there is a strict rule regarding immediate use steam sterilization, IUSS, or flashing, of implants. Implants should not be flash sterilized unless there is a documented emergency. Even then, a tracking system must be used to trace the item to the patient in case the biological indicator later fails. Many of these implants and specialized tools come to the hospital as loaner instrumentation. These are trays owned by a vendor. A strict policy must be in place requiring these trays to arrive at least 24 to 48 hours before the surgery to allow for processing. Upon arrival, a strict inventory process must occur. Technicians must verify the instruments against the count sheet, check for any missing or damaged parts, and crucially, inspect for gross soil from previous facilities. The golden rule for loaners is the all-or-nothing rule. Regardless of whether the vendor claims the instruments were sterilized elsewhere, the receiving facility is responsible for them. Therefore, all loaned items must be completely broken down, cleaned, and decontaminated by your facility before they can be sterilized. Finally, we address dental instruments. While specialized, they share characteristics with other complex devices. The most critical items are dental handpieces, or drills. These powered devices contain sensitive turbines. The processing rule is do not immerse. Unless specifically approved by the manufacturer, dental handpieces should never be submerged in water or ultrasonic cleaners. They should be wiped down, and often, they require lubrication or oiling before sterilization. After oiling, the handpiece should be run for a few seconds to expel excess lubricant so it does not stain the peel pouch during sterilization. This brings us to the end of our study. Complex surgical instruments represent the intersection of advanced medical technology and rigorous infection control. Whether you are handling a robotic arm with a limited lifespan, a fragile rigid endoscope, or a heavy orthopedic drill, one principle remains constant. The device manufacturer's written instructions for use are the ultimate authority. Never rely on memory. Always consult the IFU. This concludes our comprehensive study of Chapter 11.